All right, so I think we'll go ahead and get started. So welcome everyone to our orthopedic surgery grand rounds. Today I have the honor of introducing one of our current fourth-year residents, Dr. Alex Marks. So Dr. Marks is originally from Southern California in LA. He went to Brown for undergrad. He was a member of the soccer team and a team leader. After that, he worked as a scribe at a sports medicine orthopedic surgery practice in Southern California, and then came to UCSF first as a medical student. During his time as a medical student, he excelled. He was a member of AOA. He did a fair amount of research with our group and our department during his time as a medical student, and then we were fortunate enough to have him matched with us for residency. He's continued on his tremendous path. He's done ongoing sports research, and he's currently applying for fellowship in sports medicine. He is going to be speaking to us today about voluntary incident reporting at UCSF, the good, the bad, and what can change. I think he was inspired by an earlier SOS discussion on the topic that has prompted his interest today. So Dr. Marks, thank you for speaking today and look forward to your talk.
Thank you, Dr. Landau, for that great introduction. Wow, love it. Well, as Dr. Lansdowne discussed, I will be, following up on work done at our previous SOS grad round, looking once again at incident reporting, doing a deeper dive into why it's here, what we can do and what we can do to change it for the better. So when we last spoke about our topic at SOS grad rounds in September, you all had the following things to say, which were some strong perceptions. 2/3 of you thought that they did not enhance communication. 2/3 of you thought that they were a punitive tool used against physicians, and only 2/3 of you thought they were a tool for quality improvement. Additionally, 61% of you had been a subject of an incident report, while only a fourth of you had submitted one. Voluntary incident reporting has been around for some time and serves as a critical function for continued hospital accreditation. So there must be a reason for their existence, yet so few of us choose to use them and view them as a very inefficient tool for change. So for my talk, I decided to do a deep dive, as I've said, within incident reporting to understand its role in the hospital from a historical perspective and why it exists today, where its breakdown between its stated objectives and the reality of how it is practiced came from, and then, of course, what we can do at UCSF here to improve our system. So starting from the beginning, why does this system exist? The premier concept behind the use of voluntary incident reporting is that it allows us to learn and analyze near-miss events. Near-miss events is one term used to define an unplanned event that could have led to patient harm but did not. The idea of using analysis of events where injury did not occur to understand the contributing factors for injuries themselves was championed by an American industrial engineer named H.W. Heinrich, who in 1931 published his book, Industrial Accident Prevention, A Scientific Approach. In it, he put forward this concept having reviewed some 75,000 industrial accident reports, which is now known as the Heinrich Triangle, in that for every 300 near misses avoided, you can potentially avoid 29 minor injuries and 1 major injury. Frankie Bird later championed a similar concept, though his number was a bit larger, stating 600 near misses would cause 10 minor accidents and 1 major accident. Nonetheless, the underlying concept is the same, that understanding and preventing near-miss events would in the long run prevent accidents, and that it is the responsibility of the companies to improve the work environments to avoid these events. The aviation industry was the first to begin developing systems in the 1950s and had one of the earliest industry-wide reporting systems tasked with capturing information on near misses. The Aviation Safety Reporting System, or ASRS, was launched in 1975 in response to the tragic crash of an airliner at Mount Weather in Virginia. This crash and factors contributing were foreshadowed by a near-miss event involving an airline on that same approach 6 weeks earlier. We would subsequently see this arise in multiple other industries over the following 3 decades, as prior near misses were identified as precursors to the 3 Mile Island nuclear disaster in 1979, the Ladbroke Grove rail crash in 1999, and the Columbia Space Shuttle disaster in 2003. Medicine around a similar time joined this movement with the landmark healthcare report from the Institute of Medicine that I'm sure we've all heard of, To Err is Human, which spearheaded the modern patient safety movement. Many states had already had mandatory reporting systems for serious adverse events, but in it they explicitly advocated for development of 2 systems, both mandatory reporting systems and voluntary reporting systems, with voluntary reporting systems charged for capturing patient safety concerns from events that did not lead to harm. A quote I want you all to ponder as we go about this talk that I pulled from the original To Err is Human text goes as follows. Reporting systems have the potential to serve two important functions. They can hold providers accountable for performance, or alternatively, they can provide information that leads to improved safety. Conceptually, these purposes are not incompatible, but in reality, they can be difficult to satisfy simultaneously. This eventually led to the Patient Safety and Quality Improvement Act of 2005, establishing a system of patient safety organizations and a national voluntary reporting system database designed to enhance the data available to assess and resolve patient safety and healthcare quality issues. Here is a brief schematic of the process here at UCSF. An unexpected or adverse event occurs, and the first question the reporter must determine is if the reported outcome was moderate harm, severe harm, or resulted in a death. If no, the event is entered into the IR system with facts as known at the time of entry. From there, the unit leader or file manager will review the incident reports and must also decide if the outcome is moderate harm, severe harm, or death. If moderate or severe harm is identified here or at the beginning, this is escalated to senior leadership in a tiered process, which we will discuss briefly later. However, regardless, an investigation will begin from the unit leader, looking for gaps in process, seeking to address why and identifying concerns. The involved staff or clinician will also provide facts and insights to the investigation and seek why, offering suggestions for mitigation in the future. For the majority of incident reports, this process will slow here with the unit leader having identified an action plan and entered the appropriate findings in the incident reporting system. This also happens working in tandem with the patient safety specialist of our patient safety office, who additionally will review all incident reports, escalate as needed, monitor for completion, and complete final documentation before the file closes within 30 days. So to improve the system, we first need to understand what are the perceived benefits to the hospital system. And the three that I've identified in my research, which I'll walk us through, are the development of safety culture within the institution, improvements in employee engagement, as well as the development of the AHRQ's network of patient safety databases. So starting off with safety culture. Creation of safety culture is by far and away the most commonly cited and evidence-backed benefit of these voluntary reporting systems. One of the first studies to look at the effects of a national reporting system came from England. In it, they looked at trends in reporting rates from their national voluntary reporting system between 2004 and 2005. Additionally, the NHS annual survey required to be filled out by staff for accreditation includes questions on safety as seen to the left. This study looked at the relationship between reporting rates of incident reports and the proportion of staff at each hospital giving positive responses to the NHS staff survey. Questions such as, employer engages staff to report errors, near misses, or incidents, or employer does not blame or punish people who make errors were asked. As seen in Table 3, they found overall positive correlation between positive data on safety culture and rates of incident reporting. Similarly, a single 250-bed acute care hospital in Pennsylvania ran a Good Catch campaign to improve peri-op safety. A good catch is their version of a near miss, defined as any event that could have resulted in patient harm had it not been prevented or discovered. Their campaign consisted of threefold changes described as here: one in education, which included 5 educational sessions amongst staff over 2 months. Changes to the reporting system from 3 separate systems to 1 standardized system. And improvements in cohesive communication, having weekly debrief meetings to go over reports and goals posted to the board to the left. They found that within a year of implementation, they increased from 85 good catches in 2015 to 391 in 2016, with 66% of them coming from the OR, followed by 16% for PACU and 10% from anesthesia. Additionally, when they're looking at staff responses to the annual AHRQ survey, they found in 2016, after the implementation of the campaign, there were significant improvements in all questions on patient safety, as seen by the black and blue. This is also much greater than the national averages, which are in the lighter blue to the right of the 2016 values. So I think it's important to note that nearly 50% of the respondents still felt that there was a punitive response to error. So despite the belief that these systems improved communication openness, gave feedback on error, and facilitated organizational learning, employees still felt that the system had punitive responses to error. And those were just 2 examples of what has become a large body of literature supporting its use in promoting safety culture. Additionally, some advocate for the use of the system to improve employee engagement. The Harvard Business Review published an article in 2022 focusing on 3 ways to improve worker engagement within hospitals. Prioritizing patient safety and building a culture of accountability were the first 2, with the third also directly being tied to patient safety. In this review, they specifically cited use of incident reporting as helping to develop this culture. They argue incident reporting establishes clear and transparent procedures for reporting and addressing incidents, behaviors, and actions that undermine quality of patient care and staff and patient safety. These measures help develop a culture of speaking up and have a strong support of the hospital staff. And while employee engagement in and of itself should be worthwhile enough, this infographic from a company that helps develop incident software sheds light onto other incentives of the system. As we know, nursing shortages have afflicted multiple hospitals in the country. Some argue that voluntary incident reporting gives all members of the staff a voice to effect change to the system which they work. This improves retention, productivity, customer service, and ultimately profit. Now, there are no peer-reviewed articles to discuss the claim that incident reports can improve employee engagement and lead to increased profits to the institution, but it is an argument used to support the continuing use of these systems, and I'd argue not an insignificant one, given that the maintenance of culture and accountability is paramount to healthy work environments for all employees. And the final proposed benefit of these systems is that can generate a lot of data. If we return to our original diagram of the Patient Safety Quality Improvement Act from 2005, you will see in the bottom left this thing called the NPSD, or National Patient Safety Database. Since 2012, the AHRQ has begun collecting data of voluntary submitted patient safety incidents, compiling 2.6 million reports over a 10-year period. The NPSD dashboards and chart book were initially published in 2019, based on more than 1.1 million records reported to healthcare providers to approximately 15% of the AHRQ listed patient safety organizations. Since then, they have published annually with the 2023 chart book, including all 2.6 million records. They collect data on 9 safety events as listed here. They categorize data related to falls, medications, pressure ulcers, surgery/anesthesia, perinatal, medical/surgical devices, multiple, and then other. Data is broken down by year, with nearly 50% of the data each year being not as helpful as ideal, being listed as other. Interestingly, of those 9, they identified 6 of which to ask follow-up event-specific questions on the input survey. However, sadly, there were no detailed sections for surgery or anesthesia because too few of these submitted reports were sufficiently complete for meaningful analysis. But they do collect a lot of data. They collect data on the location of the event, whether it was an incident or near miss or unsafe condition, actions that prevented near misses from causing harm, of which in surgery or anesthesia, a failsafe designed into the process was most commonly cited. And of course, contributing factors to the event, which I'll have you note that 42% are communication, which is the most contributing factor reported in surgery or anesthesia. And through this work, they've come up with 3 focus dashboards where they've tried to look at factors specifically related to falls and then one on COVID. And while there is a lot of data in these reports, they are still in the collection phase, with the reports currently only intended to show the capabilities of the data. Though it is a promising step for aggregation of a large amount of incident reports, and we'll see where this takes us. And now I want to transition to the concerns or some of the issues with the system. The 3 concerns I've identified and will discuss are limited evidence of reduction in patient harm, bias within incident reporting, and then cost effectiveness as well. Aside from improving safety culture, other ways studies attempt to show benefit is through reduction of incident reports after an intervention as determined by a prior incident report. This analysis from a single institution made real-time observations from external staff members before and after implementation of various improvement actions subcategorized into 4 categories of improvements, either in organization, medication, communication, and technology. 12,000 observations, both before and after the implementation, were made as to whether a patient safety incident occurred or was avoided. Breaking it down by category, they found interventions in medicine, technology, and communication led to a reduction in patient safety incidents observed. For example, in medication, developing a protocol for use of high-risk medications resulted in a 13% reduction in observed patient safety incidents regarding high-risk medication. In technology, electronic prescribing in the emergency department resulted in a 16% decrease in safety incidents. In the area of communication, developing standardized checklists for discussion points and transfer of care from the emergency department resulted in a 6% reduction in observed patient safety incidents. And then within the area of organization, while some interventions did result in a reduction in events, such as the use of patient identification wristbands in the emergency department, overall interventions in organization did not result in a significant reduction in observed patient safety incidents. Taken together, they found a 63% reduction in third-party observation of near-miss events. They also performed logistic regression of factors associated with interventions with significant reduction in observed patient safety incidents. In it, they found the highest odds of an intervention leading to a significant reduction in observed events was if the intervention was focused on reducing an adverse event as opposed to a near miss. This was also followed by if the intervention was generated through the use of a group discussion or root cause analysis. So there is some data to suggest that having an incident report and creating an intervention can reduce the rates of previously reported issue or third-party observations of the issue, particularly if the intervention is related to an adverse event and the change is one related to medication administration, improvements in technology, or communication between providers. And this is only a single study, but there are barriers to show that using and learning from incident reporting can decrease the rate of the incident itself. Though because many of these are near misses and themselves do not result in errors or harm, it begs the question, is there any data to show they actually reduce harm or outcomes? Or do the improvements in safety hinge on believing our original Hyman triangle from 1931 that 300 near misses prevents injury? One of the studies mentioned earlier that demonstrated improved safety culture after development of a national reporting system in England in 2004 also looked for any correlations with easily reportable outcome measures and found no correlations with the following. They found no correlations with standardized mortality ratios or between three commonly used patient safety indicators relating to number of deaths in low mortality healthcare resource groups, number of decubitus ulcers, and number of postoperative sepsis cases. And although that study is an isolated study looking at a single hospital system and is not alone in its findings, this systematic review out of the University of Surrey in England analyzed 35 studies, 16 of which were published in the United States, and found that while incident reporting systems can lead to single-loop learning, such as changes in processes, there is little evidence that they ultimately improve outcomes or enable cultural change. In 2022, a group from the University of South China did a scoping review of 67 articles within the inclusion criteria, with the inclusion criteria being a peer-reviewed article that reported on near-miss events as the primary or secondary outcome and were written in English. They looked at a variety of metrics such as contributing factors to near misses, barriers and incentives to near-miss reporting, and then problems within the study. The one takeaway from their analysis was that the only shared outcome indicator amongst studies was the frequency of near misses and the assumption that decreasing near misses improves patient outcomes or decreases patient harm. This thought led to a follow-up review in 2023, in which this group from the UK did a systematic review finding 19 articles that evaluated the efficacy of actions made after a single or several patient safety near misses or good catches. 16 were based in the United States. They found 10 articles included evidence of human-focused actions, such as educational interventions. 13 focused on administrative actions, such as decision-making algorithms or guidelines. And then 11 involved the introduction of new technology. What they found was that by and large, these interventions were focused on changes in human behavior, and that the conclusion that harm was reduced was extrapolated or assumed in the assumption that decreasing events reduced harm. In it, they argued that the common cause hypothesis, which is our original Hyman triangle generated in 1931, is still an underlying assumption of much of this research and should be more rigorously questioned to its applicability in the modern healthcare system. And despite having mixed opinions on their efficacy, a common consideration is that if there is no harm with these systems and a possible upside of patient safety, then why question them? Well, that's not what a group out of Stanford would argue. A qualitative analysis performed on 401 reports, which is their form of voluntary reporting from March of 2011 to February of 2020. They specifically looked at reports that were not patient-facing issues and involved perceived disruptive behavior by a faculty physician. These were coded into themes and by severity, as seen to the right, with 1 being least distressing, such as eye-rolling sarcasm, and 3 being most distressing, such as physical altercation. They use a benchmark of 3% difference from the demographic characteristic as significant. And despite accounting for only 21% of safe reports, female physicians had disproportionate representation among references to communication, conversational conduct, and the lowest severity level, while male physicians had disproportionate representation for ignoring or omitting procedures, process issues, and physical intimidation. This study also broke it down by race and ethnicity and found that African American physicians had disproportionate representation for lack of communication and process issues. Asian physicians had disproportionate representation for lack of communication, process issues, conversational conduct, and the lowest severity level. Latinx physicians had disproportionate representation for conversational conduct, while white physicians had disproportionate representation for ignoring or omitting procedures, verbal abuse, physical intimidation, and the highest severity level. Taken together, the conclusion of that study is that female physicians and physicians who are members of racial and ethnic minorities were more likely to be reported for low severity communication issues compared with their white and male counterparts, respectively. This suggests that there may be a lower threshold for reporting events when the subject of the report is female and/or a member of a racial or ethnic minority group. And although outside the full scope of this talk, we do know that there are incompletely understood associations between bias and burnout. There's also correlational evidence that bias affects clinical decision-making. So if these incident reports facilitate our own inherent bias towards colleagues, do they also facilitate those implicit biases affecting how we take care of patients together with them? Now, briefly on cost. This retrospective review was a single institution study which analyzed over 40,000 incident reports from 2015 to 2019. This graph demonstrates the number of cases over the study period for the department, per department. The graph is color-coded for severity, with blue bars depicting number of incidents reported that were mild, with level 1 denoting no harm to the patient. And at the other end of the spectrum are the red bars depicting incidents with high severity of injury, the most severe which is level 5, resulting in the death of the patient. They reported that the orthopedics department had 1,500 incident reports over a 4-year period at a single institution in Japan. This paper from the NIH in Britain estimates on a conservative side that it takes the reporter, manager, and patient safety office an hour to process and manage each incident report. So if we do the math, that is 30 hours per month spent responding to incident reports, or really roughly about an hour per day. A 2016 study out of the UK did look at the actual cost per incident reports in their hospital system. A random subset of 150 incident reports from 2014 at the Birmingham Children's Hospital was analyzed. A questionnaire was sent out to involved members of the incident reports to determine how long it took to complete the incident report form, investigate the incident, read and process incident-related summary emails, and for a subset of them, have PICU safety team meetings. They then determine cost per minute for the involved staff in each of the 4 elements of the incident report process through evaluation of NHS pay scales. For costs associated with email distribution, an average of 6 minutes was spent on reading emails sent to multiple members of staff associated with a given incident report, leading to an average of 167 pounds per incident report of 130, otherwise known as total cost per IR for that portion of the incident report. 2 wards have safety teams that had additional meetings, leading to an additional 37 pounds per incident of 150. Additionally, the PICU has its own safety team, as I said, that is involved in a third of incident reports, leading to an average of 71 pounds per incident report of 150. For all other elements of incident reports and members involved, the time spent per incident report was multiplied by the cost per minute to get the cost per IR1, which was then divided by the number of incident reports each group was involved in to get the average cost per IR out of 150, or total cost per IR. And so when added together, you get the average cost per incident report for a random subset of 150 incident reports from the UK in 2014 which this study found was 337 pounds. Now, if we assume, as Hyman did, that it takes 300 near misses events to prevent one major accident, then it costs 90,000 pounds to prevent one major accident, which compared from 2014 United States malpractice payouts for certain never miss events. The costs do seem worth it for some larger events, such as wrong-sided procedures, but even for never miss events, such as retained foreign bodies, the costs of 300 incident reports are greater than the cost of the malpractice settlements that pay out for these events happening. So I do want to stress it is important to remember that we do things not because they are cost-effective in healthcare, and I'd argue that the included adverse events should never happen in the modern healthcare system, regardless of the cost of the intervention. Now, what if I told you we can make the system better, which will be the focus of the remainder of my talk? So the identified benefits have been safety culture, employee engagement, and the robust data of the NPSD. Concerns that have been identified are issues in limited evidence on reducing adverse outcomes, implicit bias, and then cost. So to that end, I think the following 3 points should be takeaways from my talk and are things I think we can address here. We should focus on improving data analysis, work on removing a culture of negativity, and then develop a system of physician advising. In 2013, Vanderbilt instituted a system they called CORS, Coworker Observation Reporting System, which is their form of coworker reporting of disrespectful and unsafe conduct. The system is not dissimilar to the one at UCSF, but it's gained a lot of traction for its reporting that 80% of recipients labeled as having a pattern of behavior do not receive a single incident report in the following year after being identified. The system defined has an employee submitting incident reports. The report is reviewed for unlawful and egregious conduct, then uploaded to the CPPA, which is the Center for Patient and Professional Advocacy, and analyzed. The report is processed within their database to determine if the involved individual has any prior reports and reviewed by a CPPA operational leader. Then for people who have only a single report, a trained departmental messenger or faculty champion will deliver messages to said individual to engage in cup of coffee conversations, after which final documentation is completed. In their analysis over a 3-year period, 95% of faculty had less than 3 reports, with only 3% of faculty having more than 3 defined as a pattern. Those with a pattern of behavior entered an interventional process with resources to help modify this behavior. Now, it's come to my attention after doing research for this talk that UCSF is in discussion of adopting this system, which I think has tangible benefits, one of them being a proven track record of data analysis. Vanderbilt has an organization, the Center for Patient and Professional Advocacy, which is run by a combination of both physicians and other medical professionals designed to help implement their core system, as well as conduct professional development training, education, and research on voluntary coworker or observation of reporting or hospital systems. The CPPA has published multiple articles on the topic of patient safety in commonly accessed medical journals, specifically utilizing their system and their de-identified reports of unprofessional behavior. While no broad sweeping recommendations have been made, they have published multiple articles, including one at JAMA Surgery, where they reported that a higher number of coworker reports about unprofessional behavior in the 36 months before a patient's operation was associated with an increased risk of surgical or medical complications. It is important to note that this study only accounted for case complexity by length of case and then general patient demographics such as age, BMI, and ASA, which in my opinion is a big confounder of that result. While this is not much, it shows me that at least the reports can be accessed and analyzed in a standard fashion and published in journals that we more commonly read. Also, I would note that as these datasets become more readily available, it will be interesting to see the use of large language models in looking at the vast amount of unstructured data. This systematic review identified 35 studies that demonstrated the ability of natural language processing to perform a classification task on incident reports or detect adverse events for medical records review. These studies were able to demonstrate the ability of natural language processing to categorize incident reports, but largely by binary classifications such as drug error or no drug error, fall or no fall. But that's far from our ultimate goal, which would be to understand why these incidents occur and explore the non-structured text elements that will lead to us figuring out contributing factors. And if you remember the graph I showed you earlier of the category of incident reports from the NPSD chart book, which was the summation of over 2 million reports from the AHRQ in 2023, most years, 50% of them were categorized as other. Generative AI models may assist in categorizing these unstructured other sections into meaningful categories. And interestingly, when researching this talk, I found that the NHS in England is looking for a PhD data scientist to do this for them, or interested for them. So there's definitely interest here, and we here at San Francisco should definitely be at the forefront of it. And very recently, I found this data is quite accessible and requestable, though you do need to know where to look. If you go to safety.ucsf.edu and the page on reporting, you can find their incident reporting system by clicking one of two hyperlinks listed here. From there, you log into their system RL solutions and go to the bookmarks in the top right and click references and FAQs. In this section, you can find actually a lot of information on the workflows of incident reports, how to submit, and what specific data is currently analyzable. Most importantly, in the cross-bay incident reporting workflow aids, you can find a document here that gives you hyperlinks to the UCSF IT website, where you can either request specific data or access to a subset of data of a database for both the UCSF and UCSF CHO. Here's what the form looks like, and I encourage any interested to particularly those with an understanding of natural processing models to consider looking at this data. I only recently became aware of this process really last week, so we'll be applying for application or access to the data soon, but I do not have it for you here today. Secondly, I think we must work to continue to remove the culture of negativity behind these reports, remembering why they were created to evaluate factors contributing to near-miss events and not for punitive measures. In other industry, reporting is encouraged and rewarded, while frequently in medicine there is investigation and sometimes punishment. We must remember that safety occurs through all action at all levels. It is due to factors that are non-linear in nature and that do not need to be a product of errors, but rather a result of unanticipated results of normal variations of the complex work that we do. To that end, I think focusing on both factors contributing to the event, but also identifying and enhancing that within a system that allowed it to recover from the accident trajectory is vital. Now, to show an example and attempt to dispel some of the hesitancy to admit errors, I must include an incident report of my own. I accidentally ordered a heparin DVT prophylaxis for a 9-year-old patient who underwent a complex surgery. They also commented on it being the wrong dose, as my dose would be underdosed for her size, and I did not respond for additional questioning. The response, I thought, was very valid, in that it resulted in a coffee cup conversation of BTE risk assessment in pediatric patients. I think we could have also included the positive trajectory systems of pharmacy checking of anticoagulant medication, mandated checking of dosing, such that I did not prescribe a medication above the recommended dose, as well as a discussion of the fact that the adult ortho order set does have common categories of orders needed for admitting patients to avoid other errors resulting in subsequent incident reports. Additionally, there is a movement by the Joint Commission, or JCO, to promote zero harm. The underlying premise that safety only exists when there is no risk of an accident with harmful consequences. What began to err is human in 1999 to reduce harm is now a focused goal to reduce harm to zero. A goal of zero infections, zero complications, and zero reported safety incidents. While I do think this goal is meaningful and worthwhile aspiration, I do want to emphasize that we never lose sight of it within the rest of the context of taking care of patients, as setting a goal for zero harm can have the unintended consequence of labeling these near-miss events as punitive in nature. In a field in which one of the seminal conversations we have with patients is that of risks and benefits, how then are we to proceed if any adverse event associated with that risk is increasingly intolerable by our institution? Our 4 principles of ethics, being autonomy, non-maleficence, justice, and beneficence, are always in some ways at war when we choose treatment plans for our patients. An overlying emphasis on non-maleficence can lose sight of why we take care of patients, not just to do no harm, but often because the patient desires to improve some aspect of their life and knowingly agrees to proceed with the associated risk of care. One solution, which I know has been debated extensively at higher levels, is to acknowledge that while zero harm campaigns are aspirational, words such as zero as possible and setting a firm goal to zero has a potential effect to lead to perverse incentives to limit reporting and contribute to the demoralization of healthcare providers who cannot hope to attain such a goal. UCSF, fortunately, does have many other things within its True North pillar to balance out our strategic priorities for taking care of patients. Though we do include achieving zero harm as our goal, opposed to limit harm or aspire for zero harm. So how do you consider? And then in further addressing this culture of negativity, I think we must also have a frank discussion about the role of implicit bias. Training modules discussing the benefits of incident reporting and promoting its use must also discuss that it can be a vehicle to facilitate one's own implicit bias. We discuss frequently how implicit biases can impact our interactions with patients, and we must also discuss how they influence our interactions and reporting of colleagues. And then the third avenue is physician advising. I was recently able to talk with the director of Berkeley Center for Law, who specializes in employment and labor law, who informed me the use of the term advisor is somewhat less confrontational than advocate, hence why I use this term. But broadly, it is to put that you are not alone in dealing with these issues and have support of a peer. This intervention diagram from CORE's website, which begins with a coffee cup conversation on one end and can escalate to disciplinary intervention on the top of the pyramid. And my argument is that there is a role for physician advising at every stage. Within stage 1 and stage 2 interventions, physicians are to undergo coffee cup conversations with trained messengers who have received training on how to navigate these conversations in a non-confrontational manner. My hope is that we consider having these messengers be peer messengers that don't have leadership conflicts of interest, which I believe will do more to create a culture of ownership with these issues. As we implement this system, having people within our department across multiple levels, from senior to junior faculty and possibly even at the resident level, will help develop a sense of ownership within the system. And research does support incident reports being effective and used when owned by clinical teams. So by having peer messengers within the department and without conflicts of interest, such as controlling your promotion, you maintain some ownership despite oversight from an outside organization. Now, I do acknowledge that puts the onus on us to be engaged and want to change our system, despite all of us having other duties to our colleagues, to our patients, and to our families. However, many of us have received or have been asked to comment on an incident report at some point during our trainings or our career, and can hopefully acknowledge that having guidance on how to respond to these inquiries by a peer may dampen the moral injury you inherently feel when you are asked to respond to it. Well, this is not necessarily an advising group. A team of nurses, PAs, and residents at Mount Zion met over Zoom last week after being approved to start a work group. Our goal is to foster a collaborative environment amongst respected teams, improving a sense of trust and togetherness to build a positive climate at 5 North. Everyone should continue to use the formal IR system as appropriate, but at least on the resident side, we hope to proactively improve communication and cohesiveness to limit avoidable breakdowns in communication, causing undue frustration between colleagues. This sense of ownership of issues cannot happen at every level and with every system, but I'm excited to see the results of this pilot group. And the level 2 interventions include a written corrective plan, which is developed by an authority figure such as a department chair or CMO, which can definitely feel more punitive in nature and is less likely to be a close peer delivering the news necessarily. Similarly, I think we should seek out physician advocates or advisors to help within this process. The CPPA does host many activities for professional development, including courses discussing with legal experts and roundtable discussions on how to assist individuals who require guided intervention. These courses should be available to physicians as part of a restorative justice to help aid rather than punish the physician. They also hold train the trainer models to support faculty on partnering institutions such as UCSF in learning coaching skills on how to have these coffee conversations about professionalism concerns with peers. We as a department should consider having many members participate in these models if we want to have ownership of this process. And I can't discuss outside resources without briefly discussing some we have here at our disposal for physician advising. While not specifically an advisory committee, the FSAP, Faculty and Staff Assistance Program, provides short-term counseling to any UCSF faculty or staff which does include residents, regarding an organizational concern having a significant psychological or behavioral element, which can include issues of safety, conflict, communication, and grief. There you can meet with a team of licensed psychologists or postdoctoral trainees offered at no cost. These sessions are limited to 4 sessions, though I'd hope in a model promoting for restorative justice, those undergoing intervention within the system can receive additional counseling or the appropriate resources. Additionally, there is the UCSF Office of Ombuds, which was established in 2011 to promote a supportive learning environment and working environment at UCSF by providing problem-solving resources that are protected from disclosure. This office offers a safe, confidential, and off-the-record place to discuss campus or medical center workplace issues and explore possibilities for informally addressing concerns. UCSF Ombuds, will listen and review matters, help identify options, make inquiries and referrals as appropriate, and or facilitate resolutions in an impartial manner. Though it is important to note they do remain impartial and do not play a role in advocacy. And so while both organizations are helpful, I believe there is still a role for a physician advisor that does not have a conflict of interest to help and assist one in navigating these processes. So in conclusion, voluntary incident reporting seeks to learn from near-miss events, helping to establish a culture of safety within healthcare institutions. Limited evidence of reduction in patient harm and implicit bias within reporting continue to be issues with these systems, and that improving data analysis, facilitating physician advising, and removing the culture of negativity can help the system work toward this goal of eliminating patient harm. None of this would be possible without the patience and mind of my loving wife, who put up with countless rants and run-throughs of this talk, as well as my parents and in-laws for their unyielding support of me chasing my dreams. As well as the people listed here, including Dr. Diab and Dr. Lansdowne, who helped me run through versions of this talk, Melissa Karasis of the Patient Safety Office, and Dr. Tay for familiarizing me with the process here at UCSF, and the rest of these individuals for pushing me to pursue this project. Thank you for your time, and I'll take any questions.
All right. Thank you, Dr. Marks. That was great. I think we do have some time for questions, discussion. And if anyone is on Zoom, feel free to unmute. And Dr. Lee.
Thank you. I think this is a topic that's like particularly interesting for me because I feel like that I think the biggest thing is the culture of negativity. And one thing that we can do is to increase communication. I want to know what your thoughts are on having like a roundtable when someone writes an incident report, just getting everyone in the same room and sort of discussing the situation. I know you might look negatively because sometimes you want it anonymous, but I think just having everyone at the same table and sort of discussing the issues at hand could improve like communication.
Yeah, I think I thought a lot about how to improve that culture of negativity, and I do think communication is pretty paramount to that. That Mountain Time work group hopefully will have some of those elements. Having less anonymity is important, but sometimes knowing a person and building a relationship does help prevent some of those issues. So I think some things I grappled with providing that as a specific avenue for change is that time is a factor for all of us. And these incident reports are definitely important, and there's a lot of them. And so I think having group table discussions for all of them can be time-consuming and difficult to organize. Not to say that those wouldn't be effective solutions, but as their research suggests, at least in Japan, there were 1,500 over a 4-year period, 30 a month. You're having what would be at least an hour long or something meeting, coordinating multiple schedules can be definitely difficult to do. I do think that for some of them, that is a potential avenue. That either reactively or proactively as well, having some ownership over our system, such as at the OI, we generally know all the staff there because we spend so much time there. We don't always spend as much time in other avenues, such as the ED or on certain floors within the hospital system. And thinking about how we can proactively be a part of those teams, I think will help improve some of that communication.
Yeah.
Alex, you referenced restorative justice. The one of the parts of that, pillars is these community circles, which is what Nico is referring to. They just become so formalized that they become unwieldy. But that is an effort. And restorative justice is different than what we have now. I mean, our institution is struggling with this. They believe in the concept, they can't roll it out in the same way. There's still sort of crime and punishment approach, and then they try to get back to something like that. But Professor Fisk of Berkeley's law school told us very plainly that the institution has no responsibility to provide advocacy for us. And the ombudsman has no authority of any sort. So do you feel like that should encourage us as a department to develop this as a program?
I do. I think position advising, that's kind of why I put the big picture of all of our smiling faces, because it is a little bit of a, self-searching or a soul-searching goal, that there likely won't be any large, sweeping UCSF institutional mandates to have a physician advising group. And a lot of it will be us wanting to have some control of the change within these systems, as well as supporting our colleagues in a more structured and formalized way. We all have mentors within the department which we can reach out to when we're concerned. But I think having some type of, at least within our department, and per minimum within the system I work in, which is a resident system, I'm sure we can figure out some way to make that system a real one. But I think it is up to, us as a department and us as individuals to start some of that movement. I don't think it will necessarily come from the top down above as a UCSF-wide mandate.
We'll go to Dr. Wostrak and then see Dr. Barber's hand up on Zoom after Dr. Wostrak.
Thanks, Alex. That was an excellent talk. I really appreciate all the work you did into that, and your slides were fantastic. I think if you could share your talk with the group, that'd be great. I was really interested in that article from Stanford, looking at the bias, and I had a couple questions related to that article. Number one, was there any follow-up? I mean, those results are so just staggering. I mean, the bias is very clear in there and really interesting. Did they do any education on both sides? So education on the population that submits the preponderance of those reports, kind of, hey, here's the bias in what we're seeing with these incident reports, kind of making the reporters aware of that. And did that change? And then any sort of action items that you think of with how to make that a better system based on that data?
Yeah, I think that paper was one that it really sparked a lot of interest in my previous talk. As far as I was able to research, I didn't see any follow-up discussion articles or opinions about interventions that ever did specifically in results to that paper. I'm sure that some of those faculty distributed and had talks internally, and I hope that it did enact change within their institution. Though at least I couldn't find anything kind of officially published in terms of changes. And in terms of things I think we can do, I mean, I think at the minimum, there are modules in how to utilize the incident reports. And I think part of those modules should also briefly include some discussion of how they can facilitate some of our bias towards colleagues. Not that they shouldn't be used, and not that bias is inherently evil. I hope we're at a time in the world where we can understand that we all have implicit biases and they influence our interactions with people. This is not viewed as a negative, but it should be viewed as understanding how your perceptions of people from your lived experiences can continue to influence in the use of these systems. I think in some fashion that should be part of the education or formal discussion we have on these systems.
All right, I think Dr. Barber is there. And if not, we can go to Dr. Tay, who also has his hand up on Zoom.
Yeah, Alex, wonderful talk. Having fielded a lot of these for our department, the core system was created because it decreased the potential for they have proven in their own institution, Vanderbilt, that it decreased the potential for error. But the interesting thing about it is that the people that are sent to do your cup of coffee often have no idea what you actually do, because they're not typically your peers. And having an ENT doctor come and talk to you about something you do for spine is going to be a little bit difficult because they actually don't know what's going on in your department either. A lot of the issues that come up from a professional standpoint, at least from the professionalism committee from the med center that I belong to, that we look at all the IRs for professionalism, appears to be kind of incited by the system that we work in. And the system and the environment is not necessarily doctor friendly, nor is it conducive to the push to do more volume. And we have a conflict here where physicians are constantly trying to be more efficient, yet the system does not allow that. And it creates a real conflict at the point of care. So can you comment on that and what you've read about this particular issue as it relates to professionalism and incident reports relating to that?
I think you bring up, I will answer your question, but also make a point in that question too. You bring a great point that discussing professionalism incident reports, it's quite hard to actually find literature on it because in general they are de-identified. There was that Stanford paper, and I think there are some other reports as well. But even in my own quest to look at it here at UCSF, there are many processes that I will have to undergo to actually access those reports and document that data on a formal basis. I think anecdotally, and obviously you have extensive time spent looking at this, it does make sense that system issues can affect our ability to stay professional and maintain professionalism. But I think that if you have these thoughts that there's this cycle of reporting professional incidents, it being a cause of the system itself, but the system being like inflexible for change, I think it's important that we actually document this to continue to show what incident reports may not be like super helpful in actually leading to change and which ones actually do. Levi, okay, thoughts about it?
Yeah, thank you.
Alex, right away, Bobby went to the professionalism part. This whole IR thing, I think it's morphing and it's becoming more, my impression, we'll see what the data, if they ever show it to us, it's becoming more professionalism heavy, or it's heading in that direction. But its origin was safety, right? And you develop a whole system for safety, and who can argue with that? Yet you still can't show us that patients are less harmed. It's all theoretical, unless you didn't. I mean, I'd have just not seen any papers that show that patients actually have better outcomes. And if at the end of the day we're here not to fight with each other, but to take care of patients, then shouldn't that be the guiding goal?
Yeah, I think that is one of the points I put up, that the evidence supporting specifically limiting harm is limited. It obviously is difficult to associate anyone intervention into reducing harm because there are a lot that might happen. So a paper publishing in that has to be pretty robust in its methods to make definitive conclusions that their intervention reduce harm. I think another thing that is conflicting with those aspects, I do think our overarching goal is definitely to take care of our patients. I think there is a real goal that these systems maintain of creating a culture that we all want to work in, which is very amorphous but tangible, I think. And putting hard objective goals and criteria for the improvements of that culture is part of the discussion of my talk, and also I think on us to figure out what that culture means for us. So I think those avenues are kind of a little bit at battle as well, that we do have an aspect that specifically is looking at peer-reviewed articles on how to improve patient outcomes. But also we all understand that creating culture and maintaining a culture that we want to work in is important as well. And figuring out how to optimize that aspect requires use of methods that might be different from the first one, as opposed to looking at peer-reviewed articles, looking at other successful organizations, successful healthcare businesses, people whose job is to grow and maintain businesses. Those people are very important for the health of our system as well.
Yeah, Alex, great job. Hope my voice is better. It's still a little bit raspy, but great job. And I think this is a very, sentimental topic for most of us, right? Because most of us have incident report written about us, in the past. But I think that just want to make sure the department understands is that, incident report, there are two parts of it. One is really system issue or process issue. That's actually incident report. For example, wrong side surgery, blocked under the wrong patient where the wrong antibiotics given. Very different from professionals and, incident report, which is, well, Alex look at me wrong the other way, or my the raspy voice yelling and can't hear what I'm saying. So I think that there are two areas. I think sometimes when we look at the outcomes of what incident report does, we should not lump them together, because there are process improvement that has happened in this institution, with time, that make us safer taking care of patient. And it's hard to measure, even like wrong side surgery, we mark it. How do you measure that? As a volume goes up over there, is it a right thing? We all think it's a right thing, but does it really, what is the actual incidence of it? And it still happens with wrong side surgery. And when it happens, we need to know why did the process breaks down. So I think that there is some merit to the system, but I think that, as we all experience to, is that there is a move towards, more reporting of professionalism. That is, we feel, as I mentioned in previous, sessions before, that the majority of the IRs are not about people. The majority are still about system issue. But when they are, a personal, or professional in some issue, I think communication and misconception most of the time the reason. So I do encourage you having the right, a venue to allow these miscommunication to go away is helpful. I'm glad about what the group is doing at Fine Laws, in Mount Zion, because clearly that's a way that it's the positive thing to come out of the incident report. So, I encourage you people to kind of look at the system. How do we make it better? We're not going to change it, but I think there are things we take it out from the yeah. Sorry about the voice.
No, I definitely agree. And you looking at that the bias studies from Stanford, they looked at 10 years and found about 400 reports. Which is, a lot less if we think about how many of these actually get put out per month, which is 1,500 over 4 years. So I agree, the professionals are, a small subset, and one that definitely, a lot of us will eventually be a part of, and then bring a little bit of moral injury because we want to take care of patients, and we are perfect when it feels like our actions have affected patient safety. But yes, hopefully proactive interactions to improve communication can help limit some of them.
All right. I think we'll wrap up there, but Dr. Marks, great job. And also for faculty, Dr. Sabatini wanted me to remind everyone there's a faculty development program tonight at 5 p.m. on Zoom. Should be on your calendar, and developing a clinical research program. So 5 p.m. tonight. All right. Thanks, Dr. Marks.